Welcome back, everyone. In this recording, we're going to start learning about how diabetes is managed. Now, remember that it's the chronically high levels of blood glucose that causes the damage. So by keeping these levels as close to normal as possible, then the sort of short-term complications associated with hypoglycemia and hyperglycemia can be prevented or delayed, and also the same thing regarding those long-term complications of macrovascular and microvascular disease that we spoke about in the previous recording. So in terms of detailed learning objectives, they're to be able to list the symptoms of hyper and hypoglycemia, to be able to describe the treatment for hypoglycemia, including when and how exogenous glucagon would be administered, describe dietary changes that can help manage diabetes, explain why increased physical activity is a common component of diabetes management, explain why cigarette smoking complicates diabetes management and increases the risk of diabetes, and name the test that is used as an indicator of the long-term efficiency of diabetes management. So we'll begin by talking about the management of hypoglycemia, which is of course a significant risk of treatment. So people who already have diabetes and they're taking pharmacological agents can experience a hypoglycemia, and in particular those people that are taking exogenous insulin, and that insulin works too well, and then their blood glucose levels drop to dangerously low levels. Remember as well, that if there is sort of low blood glucose levels, that is damaging to the central nervous system. And therefore, you can have different sort of things happening depending on how low the actual blood glucose levels get, from things like fainting to, becoming unconscious and in a coma. And remember as well that the central nervous system can't function normally as, if you've got low blood glucose levels, because it can only use glucose as a fuel source and not fatty acids. In children, hypoglycemia is very dangerous because the central nervous system is still developing. So in children with diabetes, mild hyperglycemia is more preferable to hypoglycemia, and chronically low blood glucose levels over a period of time can actually decrease the size of the head. Now, after a period of hypoglycemia, you can actually get rebound hyperglycemia. So how does this happen? If we go back and we think about somebody with normal glycemic control, when glucagon is present, that's going to increase blood glucose levels. As those blood glucose levels increase, insulin is going to start to be secreted, and it gets to a level then where it kind of switches off or blocks the action of glucagon. So we say that insulin antagonizes glucagon, and that negative feedback between insulin and glucagon helps to regulate blood glucose levels. So when you've got insulin present, or when it's being secreted normally at the proper level, and when there's not any, insulin resistance occurring, you're much less likely to get that overshoot in blood glucose levels. However, if there is insulin insensitivity, or if there is low levels of insulin, there's nothing to block this big sort of surge in blood glucose levels. And that's why you can get this rebound hyperglycemia after hypoglycemia. And this is known as the Somogyi effect, which is hypoglycemia followed by rebound hyperglycemia. There's also another sort of phenomenon related to growth hormone, and this is known as the dawn phenomenon. And this is where there's an increase in blood glucose levels in the early hours of the morning due to those nocturnal levels of growth hormone increasing. So just to summarize this, the ratio of glucagon to insulin is absolutely crucial in regulating blood glucose fluctuations. However, in people with diabetes, these fluctuations are much harder to control. And on top of that, you also have fluctuations when people eat, and you've also got fluctuations when they exercise. So knowing the signs and symptoms of both hypoglycemia and hyperglycemia is really important. So before we go on any further, I just wanted to go through some terminology with all of you so that nobody is left sort of confused. We have this term hyperglycemia, which is abnormally high glucose in the bloodstream. To treat that, we give a hypoglycemic agent, whether that's a tablet or whether it's, injected exogenous insulin. And the effect of the hypoglycemic agent then is to decrease blood glucose levels. Then vice versa, when we have abnormally low blood glucose levels, we give a hyperglycemic agent. And the effect of the hyperglycemic agent then is to increase blood glucose levels again. So now we're going to move on and look at the symptoms of both hypo and hyperglycemia. And we're going to start with hyperglycemia. So some of the signs and symptoms then include the following. So changes to the skin becoming red and dry, fruity breath. That is particularly, a feature of somebody with type 1 diabetes and ketoacidosis, and due to that breathing pattern where they blow off acetone, and that gives that fruity breath. We also have anorexia or reduction in appetite, abdominal pain, dry mouth. Of course, there's going to be increased urination because this is hyperglycemia, rapid deep breathing, unusual thirst or polydipsia. Rapid weight loss can also occur, and that's more characteristic with type 1 diabetes, and nausea and vomiting as well. And finally, drowsiness. And I've just put in those in italics there because they are sort of the more common sort of signs and symptoms of hyperglycemia. If we then look at hypoglycemia, some of the signs and symptoms are increased anxiety, blurry vision is very common, chilly sensations, cold sweating. We also have increased pulse rate, increased weakness, shakiness, pallor or paleness, confusion and drowsiness as well, faintness, headache, and nausea too. Now, many of these sort of symptoms that we see with hypoglycemia is due to the stimulation of the catecholamines, so adrenaline and noradrenaline. And so I've highlighted as well in orange the sweating, the shakiness, and the faintness. And these are the real sort of symptoms that somebody with diabetes really needs to look out for. And I think you could probably also add blurry vision in there. And keep in mind, that the symptoms of hypoglycemia would be sort of way more common in people that are, using exogenous insulin. So in type 1 diabetes or in type 2 diabetes where the pancreatic damage is just too much. We will talk about one class of drug as well that can cause hypoglycemia in the next recording. So with hypoglycemia treatment, if it's just mild to moderate hypoglycemia, then this is pretty easy to treat. So ingestion of a sugary food, so glucose, and that glucose is absorbed quickly into the bloodstream. And then that's followed by some complex carbohydrates that then will result in a slower or more gradual release of glucose into the bloodstream. However, if somebody has severe hypoglycemia, for example, they're already unconscious, then they are not in any position to be ingesting food. So in this case, you would administer glucose intravenously or administer glucagon injection. And of course, administering a glucagon injection then will act to increase the blood glucose levels. So glucagon is a hyperglycemic agent, and it's used in severe hypoglycemia in diabetics and also to terminate an insulin coma. So sometimes people take too much insulin, and that insulin works too well, and it drops the blood glucose levels dangerously low, and they go into one of these insulin comas. Now, keep in mind that glucagon will cause glycogen breakdown, and then that glucose is released into the bloodstream. So glucagon as a therapy is only useful if there is liver glycogen available. So it's not useful at all in cases of starvation or other conditions where glycogen stores are already depleted. Glucagon itself is a protein, so it must be administered intramuscularly, intravenously, or subcutaneously via an injection. If it was taken in oral form and it enters the stomach, it's going to be digested by pepsin. It also has a short half-life and a duration of action, and this is good because you don't want it to be, raising blood glucose levels too high, for too long. Now, glucagon is the only hypoglycemic agent that we talk about in this subject, and all of the other agents from now on are going to be hypoglycemic agents. A person with diabetes will have a general management plan, which will include many of these things listed here, depending on whether they have type 1 or type 2 diabetes. So there'll be daily blood glucose monitoring, and also every 3 months there will also be blood tests, done to see how well they are controlling their diabetes. Of course, there's going to be insulin replacement, particularly, for type 1 diabetes and for some people with type 2 diabetes. The oral hypoglycemic agents are usually, only given to people with type 2 diabetes, and that's because you need some sort of insulin production by the pancreas for these agents to work. Lifestyle factors are also important. So diet, exercise, alcohol intake, and cigarette smoking would also factor into the management plan. And remember as well that people with diabetes often have hypertension, so antihypertensives are important, and also lipid lowering drugs as necessary to prevent things like atherosclerosis from progressing. Less common then are these pancreatic transplants for type 1 diabetes. If somebody, does find a donor, it might be the entire pancreas that gets transplanted, or a cluster of pancreatic beta cells. This is fantastic when it does work, because then the person, has the ability to, normally regulate blood glucose levels because they've got a functioning pancreas. But donors are hard to find. And with these transplants, there's always, the issue that it'll be rejected, or there'll be a graft versus host disease. And anybody who's had a pancreatic transplant will need to be on immunosuppressant drugs for the remainder of their life to suppress their immune system and prevent that rejection from occurring. Diet is also really important in the management of diabetes. So diets should have a reduction in high sugar and fatty food intake, and at the same time have an increase in fiber in the diet. There's much better glycemic control with high fiber diets, and overall, the combination of sort of, lower sugar and lower sort of fat intake and increased fiber will help to reduce those blood glucose level fluctuations. And overall then, reduce the risk of obesity, which is important in type 2 diabetes in particular, dyslipidemia, and also the development of atherosclerosis. As well as this, saturated fats need to be limited as well, because saturated fats will decrease insulin activity, and that's important for type 2 diabetes. And avoiding hyperglycemic substances as well is also important. So, for example, large amounts of caffeine can raise blood glucose levels. And this is probably because the caffeine will stimulate adrenaline release from the adrenal gland, and that will act to increase blood glucose levels. In terms then of alcohol, it's important to reduce the amount of alcohol consumed when trying to manage diabetes, because alcohol promotes hypoglycemia. Now, if you already have somebody who's taking a hypoglycemic agent and then they start drinking alcohol, that can then make the blood glucose levels dip too low. In addition to this, alcohol blocks the formation and storage and breakdown of glycogen. When somebody is drinking, they tend to have reduced food intake. And as well as that, alcohol can kind of, impair your judgment as well about what type of foods to eat. Or somebody might forget to take their medication, or they might take it at the wrong time. Cigarette smoking then is also not sort of recommended when you have diabetes, or for that matter, not recommended at all. Nicotine can reduce the absorption of subcutaneous insulin. So therefore, nicotine antagonizes the effect of the insulin, and it means that insulin's not going to work as well, and therefore blood glucose levels will remain high. It also decreases the responsiveness to insulin. So if somebody already has insulin insensitivity issues, that's going to be a problem. It will also cause inflammation, nicotine, and inflammation in the blood vessels then will increase the risk of cardiovascular disease. And nicotine as well is a potent vasoconstrictor, and that can lead to hypertension, or if the person already has hypertension and then they smoke, it can exacerbate the hypertension. Exercise is a really important element of diabetes management. Remember that a sedentary lifestyle increases the risk of type 2 diabetes and also cardiovascular disease. And when somebody already has type 2 diabetes, exercise is really important in helping to, prevent that cardiovascular disease and from developing or progressing. Exercise itself will increase glycemic control and enhances the utilization of glucose. So exercise will reduce the fluctuations in blood glucose levels that occur as a result of the hormones adrenaline, glucagon, and cortisol. And remember, every time you exercise, you use glucose. And so in the long term, exercise training decreases blood glucose levels, those fluctuations, and also hyperglycemia. But also really important to note that each exercise bout runs the risk of hypoglycemia. So people with diabetes need to make sure that they don't exercise shortly after they've taken or administered a hypoglycemic agent. They need to sort of plan their exercise, and they might need to change the dose of their medication or change the time of their exercise around the timings of the doses of the medication. Now, I'm going to do a little bit more on exercise and diabetes when we get to the tutorial. And I guess just to summarize all of this in terms of these lifestyle factors and the management of diabetes, important to increase fiber in the diet, reduce high sugar and fatty food intake, reduce saturated fats, also reduce alcohol for the reasons I explained, quit cigarette smoking, and exercise, or just basically move more. The last thing we're going to talk about is this glycosylated hemoglobin, which provides an indication of the average blood glucose levels over the past 3 months. So the amount of glycosylated hemoglobin will give an indication of how well somebody is controlling their diabetes. Now, glucose binds to proteins, and hemoglobin is a protein. And there is a fraction of hemoglobin called HbA1c that is very prone to glycosylation. So this is what's used, and the percentage of the glycosylation then is used to determine, the efficiency of long-term management of diabetes. Even in people who don't have diabetes, there is a level of glycosylation, and it's somewhere between, say, 4 to 6%. And the aim for people with diabetes then is to try and keep their glycosylation at about 6.5%. And that's really difficult to do. So it's more realistic to think about glycosylation of 7% would be a good sort of aim for somebody with diabetes. Figures of like 8, 9 and 10% indicate poorly controlled diabetes, and will also indicate that those long-term macrovascular and microvascular complications are much more likely. Now, it is commonly recommended that this test is done every 3 to 6 months, and that kind of makes sense because the lifespan of red blood cells is about 100 days or just 3 months. So people with diabetes will probably have this test done 2 or 3 times a year.